The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk. You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers. Welcome back to Sky Women's Health Podcast. I'm so glad that you're with me today because I have a girlfriend of mine who we've had these conversations over and over again about hair loss and what to do as we go through this menopause transition so many times in the halls of her office that I said, hey, let's do a podcast episode about this. I have with me Dr. Emily Johnson, who's the founder of 817 Surgical Arts. All of you need to be going to the internet right now and taking a look at her website. Yes, I appear on there, but no, I have not had a facelift. Dr. Johnson is a triple board certified facial, plastic, and cosmetic surgeon. She's an awesome DO, a TCU grad. For those who are in North Texas, you know about Texas Christian University. And we met because she was opening a business and I support local doctors and women in business. So she's become a good friend and I just so appreciate you joining us today.
Thank you so much for having me.
Okay, tell us what your triple board certification, what is all that, like, what was your educational journey to get where you are, where you're just focusing on the face?
On the face, yes. So I started with otolaryngology, and that is pretty much where every true facial plastic surgeon starts. So we get 5 years of just head and neck surgeries. And that's everything from allergy and sinus to ear surgery, tonsils, and things like that, head and neck cancers. But then a big chunk of ours was also plastic surgery or facial plastic surgery. So I did that for 5 years. And then I did additional training in cosmetic surgery, which focused heavily on face as well. So that was where I did even more facial plastics and really learned to hone my skills on things like brow lift, facelift, rhinoplasties or nose jobs, everything to chin implants and eyelids and everything else. So that's kind of my background and what I was trained in.
Awesome. Well, I mean, I think that it's really important. Like, what do you think the value is in seeing somebody who is just focused on the face for your facelift needs versus going to see somebody who's just the general plastic surgeon?
Right. And so it's tough to answer sometimes. So I always try to focus on like the positive way to answer is I only do face. I'm highly specialized in just face. You can go see someone who does everything, but how much face are they really doing versus how much body? Because a lot of the plastic surgeons who do face and body, the workhorses would be like their mommy makeovers and breast lifts and breast
Tummy
implants.
tucks and yeah. Mm-hmm.
Right. And so the percentage of face that they do is not always going to be like 50-50. So I always focus on advertising that I only do face. That's 100% of what I do. So that's what makes me more specialized in just that.
Right. Just highly focused on this. This is all
Correct.
you do. Yeah. Mm-hmm. Yes, I didn't mean to put you on the spot. I mean, it's kind of like going to see a general OBGYN versus somebody who specializes in menopause, right? I mean, it's just a different
Correct.
level of focus. So yeah, we can all appreciate that. Okay, so we are going to get into what's going on as our estrogen and androgen changes in that perimenopause and menopause transition.
We know that there are some genetics that play into hair loss, maybe some thyroid dysfunction that could be playing in, some nutritional deficiencies, perhaps even some inflammation. And we know that there's different types of hair loss. So can you fill us in on those different types?
There's several different types. And so the most common that I typically see would be the hormonal imbalance. And that can be male and female pattern baldness. And then stress can be a big one. That's everything from you're in a car accident or you had a surgery to a life stressor, like you buried a spouse and you've gone through a lot of emotional stress. And that kind of just shuts down the hair follicle. The follicles go through a normal phase anyway, of growth, and then you shed the hair and it goes through this dormant phase for about 6 months. And so that one would be like the telogen effluvium phase. So that's the stressor. We have nutritional. Are you anemic or getting enough zinc? Things like that. And then we also have metabolic, and that would be everything, including like Hashimoto's, thyroiditis, or low thyroid. Even hyperthyroid can kind of cause some changes to the hair, and just more systemic issues. Lupus would be in that as well. And then inflammatory, like you mentioned. So that is really, I don't know how long is this podcast? um, so those are probably like the 5 biggest reasons behind hair loss. The 6th one would be still hormonal, but it's more like postpartum. So,
Oh, sure. Right. Which usually resolves on its own in a matter of
right.
4 to 6 months. We see that a lot,
Right.
right? So, but for my average population, we've talked about postpartum hair loss before. We're really focusing on that menopausal transition when we start seeing it. I'll give you a perfect example. I saw a patient this week, and she's around, late 30s, almost 40, and her biggest concern is hair loss. She's like, I'm washing my hair as little as possible. I'm combing my hair as little as possible. My hairdresser has recognized that my hair is thinning. It just comes out in gobs. I'm taking my Nutrafol for 6 months now. I've had my B12 and my vitamin D and my zinc and my magnesium. I have all of my electrodes checked. I don't know what's going on at this point. How would you approach that?
So if it's hair loss and we're not quite sure of the cause, that's when we start thinking about, do we need to do a biopsy of sorts? But getting to the root of the problem and going
No
through their
pun intended.
medication, no pun intended. Um, I use that one a lot.
Yeah.
Going through their medications can cause some hair changes. Asking about their life, again, the stressors and things like that could be causing it. And really just diving in a little bit more into their medical history, looking at the lab results, what labs were done. Do we need to maybe do different lab results? And then we get to the physical examination. Sometimes you can tell just by looking if it's, more patchy, or it looks more like more of a scar tissue, or the pattern of it. If it's in the temples versus on the top versus all over, and that kind of can point you in the right direction. But if you really just don't know what it is, then a biopsy could be something that you're looking at performing at that point.
So, talk to me about the female pattern balding. Explain to us what that typical appearance looks like.
So we all know what the male pattern is. It's typically on the top of the head or the crown right in here. But for females, it's less overall loss. So, but it's the strands themselves that are thinning, and sometimes they become more coarse. And instead of just being on the top of the head, it's all over.
Fun.
Yeah.
So,
So that nice, thick, lush ponytail that you used to have, it's like half the size.
Yes, yes.
Yeah.
Patients often report that. Yeah. And
Mhm.
then on occasion, I've had patients who are bothered by this particular complaint and we're treating their hormone therapy. And somewhere along the way, they bring mom with them to their visit. And I see that mom has the same pattern of significantly thinning hair. And I'm like,
Mhm.
oh, this is hereditary.
Yes. And a lot of my patients will be like, my mom has the same thing and I don't want to get to that point. So we kind of already
Sure.
know that that genetics is behind theirs, more than environmental or nutritional or something else. Um, but yeah, they they definitely look at their parents.
Yeah, absolutely. So I always ask, is there that family history? Have we noticed that? Okay, so I want to know kind of what you're looking at during your consult. You kind of mentioned several things. What labs are you thinking that you might add? Or what specific labs were you typically looking at?
So if they have already had labs, I'd ask to see those results so that I can know the holes to fill, like we mentioned. But typically, we want to know if there's any iron deficiency anemia behind it. So we're going to order a complete blood count or CBC and look for that. Vitamin D and vitamin B are also good labs to assess if we're thinking maybe a nutritional or something like that. If we're looking more for um, things like thyroid, so TSH level is good to look at, as well as if it's inflammatory, maybe an ESR or CRP. Um, let's see. I'm thinking about the different reasons or different causes. Zinc is a good one to look at, again, for nutritional. Biotin could also be low.
So, why is early intervention important?
Yes. So the longer the loss, it's like with anything, it once it kind of goes to that point of no return. We want to catch it in when it's in that thinning phase where the follicle's still relatively active, just to a lesser degree. Studies show that, after about 2 to 5 years of that hair loss, it is a lot more difficult to treat. And you're looking at things instead of medications or topicals, you're starting to look at like surgical intervention, like a hair grafting or something like that, because that those follicles are done. So we're wanting to catch it as soon as we can.
Okay. So, if you don't find an underlying cause, are there some first line treatments that you start with, or would you recommend a biopsy first?
Um, it depends on the severity of the loss, I
Okay.
guess. If it's pretty severe, I'm looking more at still trying to find the underlying cause in addition to starting that first line therapy. So I would consider biopsy more in that instance. If it is a more mild loss and it's just started, I would start with those first interventions. And I always say that there's like 8 different ways to treat hair loss. And it's difficult to treat because if you don't fix the underlying problem, it's going to continue. If it's hormonally related, it's likely to continue also, hopefully to a lesser degree with some replacement. But there's 6 different ways, and it's like a plant. We want sunlight, we want nutrients, we want water, right? So we're multimodality treatments.
Sure.
Um, so I always start with, topicals like shampoos or minoxidil or the Rogaine foam. If it is something that we need to do supplements for, like Nutrafol or Viviscal, just to name a few, and make sure that we're getting the nutrients that we need. Again, like a plant, we want to make sure that we're delivering everything that the hair follicle actually needs in order to create good quality hair. And then I know a lot of people are kind of hit or miss on whether or not they like red light therapy. I think for this instance, it is extremely useful. It's going to vasodilate or make sure that you're getting more blood flow to the scalp so that all those nutrients and topicals and things that you're doing it's actually delivered where we want it delivered. But the thing
Okay,
about
so
red
now
light
we want the
therapy,
link for the red light therapy.
I was about to say, but
We
the
need-
thing about, yeah, um, studies show that it's best whenever you're doing at least 20 minutes a day, 4 to 5 days a week. So it is a time investment also. So I always like to joke with my patients. I'm like, do you do a journal or devotional or drink your coffee and read the newspaper? That's a good time to put that red light cap on and just let it do its thing while you're able to sit down for those 20 minutes and just do what you normally do.
So is this like something we can order on Amazon?
It is, and there's different quality ones out there. I don't really promote
A
or
particular
anything
one?
one particular brand. There is one on the market that I've seen um, good before and afters and results with, and so
Okay.
it's called I Restore. It's a little pricey, but I think it would be worth the money, especially if you were really concerned about your loss and you really just want to ramp it up. Um, or just look at their specs and go on Amazon and try to find something that's comparable. I mean,
Okay. Well,
yeah.
I'll get that link from you and we'll put it in the show notes
Yeah,
if anybody wants to investigate. Okay.
perfect.
So we talked about topical minoxidil, but guess what? Women hate it. They
They
hate it.
do.
It's so hard to
It's like
get to the
greasy.
scalp. It's
Yes.
greasy. Nobody wants to have to wash their hair that much. So then they come asking for oral minoxidil, which is, in my opinion, is totally fine. We do a very low dose. I don't know your thoughts on oral minoxidil.
Definitely. Women
Okay.
do not want to put greasy serums, even the foam, even though it's less less liquidy. It's more of like
Yeah.
a mousse, right? But they
Right.
still just don't like that film on their hair, and so that's when oral's totally the way to go for that, and even for men.
Right. When does spironolactone come into play?
To be honest, I don't really use it a lot in my practice. If I'm going to go with a prescription, it's typically minoxidil or finasteride. Um, I Is there a role for it? Yes, I feel like maybe in the dermatological world, they prescribe that a lot more than I do.
Hmm.
But I usually just go with the bigger hitters.
Hmm. Now, when it comes to hormone replacement therapy, I generally tell patients, yes, well, this may be related to our hormonal changes in the menopause transition. Giving back our estrogen and progesterone helps to support hair growth, but it's not going to undo the loss, right? So it's just one piece of the puzzle.
Hmm. Definitely. Like I said, multimodality. You really want to find the cause if it's hormonal, but then you also need the orals, the topicals, the lights.
Okay. Now, those are less invasive.
Correct.
Yeah. So what about PRP, exosomes, microneedling? I've heard a lot of talk around these different modalities.
So PRP, or what I use now, is PRFM, or platelet-rich fibrin matrix. It's a little more pure.
Can you explain to us what that means?
So PRP is where we take a little sample of blood, usually about 1 or 2 vials worth. We centrifuge it or spin it down and concentrate the red blood cells at the bottom, the plasma at the top, and the plasma is really what has a lot of your own natural stem cells, growth factors, and things like that. So by doing that and filtering them further and concentrating all those good stem cells and growth factors, and then we inject it into the scalp. By doing that, it's kind of like like to use the phrase restore factory settings. So for skin that's not producing collagen, for hair follicles that have kind of gone dormant, it restores them and it says, "Hey, wake up, do your job." So, but the thing about PRP or PRFM is it's very quality dependent. It's how good is your plasma? How good are your growth factors? What's your age? Do you have a lot of metabolic issues? And some people just don't want to have their blood drawn. And so that's when we start looking at microneedling or radiofrequency microneedling at specific settings, as well as exosomes applied topically. And exosomes, it's kind of like PRP or PRFM, can't be injected in the US, but we apply it after the microneedling and really get it into those microchannels or the microtunneling that we've done. And again, it's those avatars of stem cells instead of your own. It's lab derived, but still very excellent at, again, just kind of turning those cells back on.
And so for microneedling of the scalp, you're actually doing the entire scalp, or are you doing just the trouble areas?
It depends on the patient. Most of the time, on all the men, it's the crown and the front. For a lot of women, it's also the same. They don't care as much about the back, but I really like to get the temple regions. I feel like that's typically where patients will see that the most, or wherever they part their hair. So we're doing an all over treatment, but then we're really focusing on those temples.
Got it. Sure. Okay. And then you mentioned a surgical option, which was hair transplant. Like, how do you know, or when are you
Yes.
a candidate for that? And what does that involve?
So I don't do it in my practice, but I was trained on it. And I like the FUE version, which is follicular unit extraction. That's where you're taking little micro plugs. And so, you think of like the people who have had hair transplant in the past, and it was like the macro plugs, and it looks like a weird shag carpet on you. Very unnatural. And so we've gotten away from that. You can also do like a hair strip and where you have a scar across the back. So we don't
Kind of
like
like
that.
when they do hair extensions.
Yes.
I mean, in terms of like
but it's like
look,
a hair extension in reverse. You're taking the hair out, and then you're able to, cut that up and put it in the areas where you need it. But I like the FUE, and it's literally, think of like a little tiny needle with suction. So you're shaving the area where you're taking the hair, which is typically from back here, where it's a little bit more dense, especially on men. And you're shaving the area. So you do have to shave your head, but it grows back. And so that helps us to take that little tiny bored needle, putting it over the shaft that's there, and it just sucks it into this canister. From there, you have, technicians who cut them into 1, 2, or 3 hair plug units, and graft them in where you need them.
So it's like a native tissue repair. You're using your own
Yes,
tissue.
it's just it's a transplant. It's like moving a plant from one location to another. So we're just moving the hair from here to where we need it.
Okay, and when are you considering this for your female patient? When are you to the point like we need to do a hair transplant?
And that would be patients who have just massive hair loss, and sometimes that is in the form of like scarring alopecia, and the follicles and the tissue is just not there anymore. And so we need to move hair from one location to another to get that follicle that's actually going to take. And it depends on the underlying cause. If we've really treated and reversed the underlying condition, but the hair follicles just petered out.
Okay. You mentioned one cause would be inflammatory. What's the solution if we feel like it's inflammation that's causing hair loss? Is that more like stress reduction, or what does that look like?
So in those instances, I mean, there's multiple different inflammatory causes. So biopsy would likely need to be done.
Okay.
And so it's, again, treating the underlying condition.
So there's not like a general, you're not saying like it's because you mentioned something about stress induced earlier. Is that like significant life stressors, or I'm just curious
Right.
if,
Yeah.
because some patients are like, check my cortisol, like.
Right. So no, the stressors are going to be like big life events. Again, like
Okay.
death of a spouse or loved one. You were in a traumatic car accident. Even things like I moved
Yeah. Or big
back.
surgery, complication,
Big
like all of
surgeries,
that that could play
exactly.
in. Yeah. Okay.
Mm-hmm.
Okay. Got it.
Yeah. And going back to the inflammation, it's really about finding the cause and then treating that with the proper medications. So,
Got it. Okay. Let's debunk common hair myths or myths about hair loss.
hmm
I don't know what
the
common
big
ones you're
stigma. I'm
hearing.
gonna say, like the biggest one is just the stigma that comes with it, and it's a women can't have hair loss. It has to be XYZ problem. And debunking the fact on your end that, oh, I can't be on estrogen or I can't be on these hormones because my mom had breast cancer and it's going to increase my risk. So
Oh, yeah.
that's a big myth that I'm like, just go see my friend Dr. Carolyn Moyers and get your hormones checked out and get on the hormones that you need.
Yeah.
It's safe. It's okay. There's a lot of, you know, is it maybe then I think it was like the 1970s that's that myth that it's going to increase your risk for breast cancer or breast cancer
Oh,
recurrence.
okay. Okay. You're referring to the Women's Health Initiative in 2002 that everyone went wild and said, breast cancer or
Yes.
hormone therapy causes breast cancer. And all
Yes.
those have been walked back. It is definitely not true. And also, family history of breast cancer is not a contraindication to using hormone therapy. So,
Correct.
yes. Okay.
That's the
So,
biggest myth that I hear.
yeah. So, myth number one is that it's only men who lose hair. What's the second most common one you hear? What about it? It's always genetic. Is that a common one?
Yeah, sometimes they just assume it's genetics because their mom had it, but then diving into their history a little bit, I'm like, it sounds like, I mean, it could be genetic still, but it sounds like you also have this other issue. Let's focus on that.
What about hair loss is permanent? Is it always permanent?
No, definitely not. Again, we go through this telogen phase, it's the normal hair cycle, and it's that telogen effluvium where your hair just your follicle goes dormant for longer than it typically does. Um, if it's true stress or trauma related, and it is that telogen effluvium, you should start seeing hair growth at about 6 to 9 months afterward. And I call it the little baby hairs, and you'll start to
Yeah.
notice that new growth.
Yeah.
They did have, a true stressor, then, we still start them on those medications or supplements or topicals and things like that in order to boost it up out of that rut so that we can get that new growth and really promote it while it's in that phase. But yeah, if it doesn't regrow after that 6 to 9 months, you're not noticing a little bit of a change, that's when we start thinking about doing other things.
Sure. I would say probably allow the same time frame for hormone related thinning as well. It's probably 6 to 9 months of being on consistent hormone therapy at a therapeutic level where you might start seeing an improvement in that loss. Well, I think you touched on one myth that, oh, it's only cosmetic, right? Well, we know women's hair, it affects self-esteem, mental health, like it's huge.
Right. And that's my entire field of facial plastics. It's the stigma of, oh, you've had something done. And, a lot of people are really reluctant, but it hurts their self-esteem. And I'm like, that's not healthy either.
Yeah. Okay. And just a plug for our part two. We're going to be doing another episode all about the face. So stay tuned for that, ladies. Okay. I want to ask another myth I hear is like biotin, biotin, biotin. It's the cure all, right? Recently saw a patient and she was on all these different supplements trying to impact her hair, this serum and this supplement. And she was taking her Nutrafol, but then she had two other supplements that were for hair loss that were basically biotin as well. And I was like, we might be overdoing it here.
As I would
So
say, they have very expensive urine at that point because
that's
your
what I
body doesn't need all of it.
that's what I
Where does
said.
it go?
Yeah, if it's not a fat soluble vitamin, people, we're just peeing it out. So
Mm-hmm. Yeah.
expensive urine. Yep.
Yeah.
Yeah. So over supplementing then doesn't help.
Correct.
And it could
Your body knows what it
potentially,
needs. So if it needs it, and if you're already on a Nutrafol, it's in there. It's in everything for the most part. That's for hair, skin, nails, biotins, and everything. So you're getting what you need. You don't need to be doing it times 3 in 3 different supplements.
okay, let's talk about some of the daily practices because I know that some people try to avoid washing their hair, not just because it's a chore, right? I'm sorry. In midlife, it just feels like a chore. There's so much to
Mm-hmm.
it, the blow drying and the styling, blah, blah, blah. So it does shampooing frequently make your hair fall out?
No, well, a lot of people are like, I lose so much hair when I wash my hair. I'm like, well, how often do you wash your hair? Like every 4 or 5 days. And I try not to brush it too much, or I finger brush. I'm like, well, you're supposed to lose on average about 200 hairs a day. So how
Like
many hairs
that's
do you think
normal.
that's
You're going to
normal?
lose about 200 hairs a day. Yeah.
Yeah. And so I'm just like, it, it sounds like it's your normal shedding. You're just not allowing that to happen. Um, and then we have the people who are super washers and they're washing their hair twice a day. And I'm like, well, okay, maybe pump the brakes on that. Also, because, you're stripping your hair of some of that healthy oil. You're drying out your scalp, and that's not healthy either. So, um, I always say once a day is fine. Um, just you don't have to be too ginger with your hair. You don't have to be too aggressive with your hair. Just find the nice happy medium.
So tell us your hair care routines that support growth or styling do's and don'ts.
Yes. So styling do's, I would say make sure that you're using good quality products on your hair. I switched to Nutrafol shampoo just as a preventative, but also just healthy scalp care. There we go. And just starting with the basics there, it's gentle. It doesn't overly strip your hair by any means, and it balances out the pH. So just make sure that you're using good quality products on your hair that aren't going to dry it out. I always say try to minimize the heat whenever you're drying your hair. Keep it on that medium or low setting if you can. If you can avoid drying your hair at all, that's also good. There's different products if you have things like, dermatitis or just flaky hair and things like that. Aveeno makes a really good uh, scalp serum for that. And just knowing what your hair needs. And those are just baseline things. That's not even like you know, my dermatitis is causing hair loss. That's just basic scalp care.
Yeah, just basics
Um,
hair care for most
mhm.
of us. Yeah.
Yeah, those are some of the do's, and then the don'ts would be again the heat, um, overly teasing, and um, over over pulling on your ponytail. Like there's something called traction alopecia. So alopecia is just hair loss. It's not balding or anything like that. Sometimes people use that just as the overall phrase for balding. Um, and it is hair loss, but then we add other identifying words to further explain what type of hair loss. So there is one called traction hair loss. So people who wear really tight ponytails, you'll start to notice like all along the edges, it's just baby fine hair because it's just holding on for dear life. So make sure that we're not, adding too much tension, aggressively brushing, aggressively scrubbing, because you can over scrub and create little micro tears, and we don't want to destroy the skin barrier of your scalp either. So, again, just do everything in moderation. Don't be too aggressive, but don't baby it either.
Okay. This has been really insightful. I hope that we've hit on most common questions. I know I've addressed several that have come up in my practice with hair loss. I think the red light cap is going to be something really exciting to see. Like, do we have randomized controlled trials on that yet, or it's just something that we're seeing some reasonable before and afters and
They're
interesting?
doing some research on it, and
Okay.
there's some introductory studies that it's good for skin rejuvenation also. So if you're going to
Sure.
get um the eye restore one. Sometimes they'll bundle like the face mask one with the hair one.
Yeah, why not? I mean,
But yeah, why not?
okay. So hair loss isn't just cosmetic. It's not just emotional or hormonal. So it's really important that we kind of take a comprehensive approach and look at all things. At Sky Women's Health, we're here to help you navigate that full picture of midlife change, including the confidence when that's hit and no one wants to talk about it. So you can find us at skywomenshealth.com. And if you are wanting to get training in root causes of hair thinning and hormonal aging, my menopause masterclass does not cover that. So when I have run out of my options for hair loss, I send them over to Dr. Johnson at 817 Surgical Arts in Fort Worth. And if you're not in the DFW area, you can certainly find a hair specialist in your area. But I want to thank you so much for taking your Saturday afternoon to talk with me and lend your wisdom and evidence-based strategies for this, Dr. Johnson. We're going to be diving into facelets and skincare routines that really work and the truth about midlife facial aging coming up next. Please tell everybody where they can find you.
All right. So you can find me on my website, 817surgicalarts.com. We also have Instagram for the practice. That is also 817 Surgical Arts, a Facebook page as well under that name. And then I have my separate Instagram account for more surgical options than just our med spa options. And that is Dr. Emily Johnson _ Fort Worth.
Perfect. Until next week, be well.